Good afternoon, everyone. Welcome to Module 8 on Service Delivery. I am Mercy Wanjala. I'm the Deputy Executive Coordinator of Afro-PHC. And we are just giving people a bit more time to join because we usually start at the top of the hour. And then let's give them about 5 more minutes. And then we will continue with the session today. Good afternoon, everyone. Welcome to Module 8 discussion for the Leadership and Management and Governance for Health System Strengthening course. Today, we'll be going through service delivery. We're giving people some time to join, and I see you at 16. I think we can get started as we wait for the rest to join us. So normally we usually have a short presentation where we go through some principal and key elements of the module, and then we have a case study, but today we'll not have the case study discussion. What we will have is discussion as we go along and a question in terms of service delivery, the challenges they are facing, and any innovative solutions they have come up with to improve service delivery, and especially from the point of view of leadership and governance. So looking at the module today and what we are hoping at the end of this module we should have learned is, first of all, we should be able to apply the principles and concept of health service delivery, which we'll go through today, and also apply the essential elements of service delivery in practice of healthcare provision. And we should also be able to describe the efficiency of the referral system, that is the components of the referral system, how they're supposed to work, and also be able at the end of it to organize and run a referral system. Then also implement the process of quality accreditation. So let's start with the concept of service delivery. We had 4 units, and one talked about the principles, then we'll go through the next, which is essential elements to improve service delivery, then look at effective referral systems, and then finally a quality accreditation. Yeah. The services, you would not have a healthcare system. So it is quite central to everything that goes on within the healthcare system. We've been going through the different building blocks of the healthcare system, and you have seen their importance. But now we are going to see the centrality of health services delivery because everything that we do, the health financing, looking for medical products, all of it comes down to somebody within the system using all those things, the money, using the infrastructure, using the technology and the health products to give a service to the community. That is why health service delivery is very central to health system strengthening. And you can see there's a huge interaction with other sectors such as education, sanitation, social assistance, labor. They all interact to bring about a good health services delivery system. So what exactly is service delivery? According to the WHO, during the WHO, from the WHO report, the year 2000, healthcare or services are outcomes of health activities that are defined as any effort, whether in personal healthcare, public services, or through intersectoral initiatives whose primary purpose is to improve health. So you see why there was an interlap between health and other sectors like the education sector, the sanitation sector, because everything that all the sectors do in a bid to improve health, whether it is school health programs, whether it is waste management, all that comes under the umbrella of service, health service delivery. And health service delivery systems have to be safe, accessible, high quality, delivering health services which are people-centered and integrated. And this is an important component of universal health coverage. Without proper health services delivery system, we cannot have universal health coverage. So this is a framework from the WHO regional office in Europe to important objectives when it comes to health service delivery. And some of the things that you look at when it comes to health service delivery are: one, what model of care are we using? Two, the organization of providers. Where are they stationed? What are they doing? What is their skill set? What services are they offering? And then the issue of continuous performance improvement, meaning with the model of care that you have and the organization you have of your providers and the services they provide, can we do that? And this is a continuous process. And then finally, management of health services, which encompasses all the other building blocks of health. And an important thing to consider when you're thinking about people-centered health systems, people-centered service delivery systems, is the issue of one, accountability, two, incentives. What will drive the healthcare workers within my system to do better, to perform better? You have to think of such things. And incentives do not necessarily just have to be things like money. It can be something like, extra days off. It can be promotion. It can be recognition at work as the best, maybe the best employee of the month, and such like incentives. And then competencies. We talked about organization of their competence, the level at which you have placed them. Then communication between the patient, the healthcare worker, and also the system. This now comes into what we talked about, I think, 2 modules back, the issue of HMIS. How do we record patients' data? How do we communicate this data to them? Is it accessible to them, and such things? And then innovations. Later on, we'll see from maybe country perspectives, also are willing to share the kind of innovations that you've come up with to improve service delivery within your systems. Then in terms of leading health services delivery transformation, remember that people are central. People are key. Without people, one, you will have nobody to serve. Two, without the people within the system providing the services, then you would not have a healthcare system providing services. The next thing is culture. You have to consider culture when you're thinking about health delivery service systems, because there's a quote that I love and I tell everyone about it that says, culture is strategy for breakfast, lunch, and dinner. So you have to consider the culture within which you want to implement your policies and your strategies to improve healthcare delivery. And most of all, leadership, the first module that we covered, because everything rises and falls on leadership. So that is something to consider as you're setting up service delivery structures. Looking at the principles of healthcare delivery, the whole idea behind them is to, one, increase access. We will later on look at what access is and the different dimensions of access. Then improved quality of services in the sector. We will also look at the quality dimension of service delivery. We will also look at that component separately. Then ensure timely responsiveness to health needs of the population. Timeliness is a key component of quality of services. If your services are not timely, then they're not considered quality. Then ensuring effectiveness of health actions, and finally ensuring provision of ethical healthcare services. So under the principles of healthcare delivery, one thing we have to always keep in mind is the laws and regulations that govern how we deliver services within the healthcare system. Because remember, one, we have a constitution, and the constitution in whichever country you are guides how you act, either as a healthcare worker or as a civil servant, or just as a general citizen in the population. Then we have international laws. These international laws govern health and healthcare. We also have national and country laws or acts which govern healthcare. You have to be familiar, one, to ensure you deliver the services, and two, to ensure that you prevent a minute. I'm not sure if that noise, or if you can hear me. I hope you can hear me. You have to initiated the health sector reforms strategy, which went on in every country. So you have to look at that for your country and also be familiar with it. So one is the issue of health insurance market reforms, two, health insurance exchange, subsidies for premiums, that depends on the country that you're in and the kind of health insurance arrangements you have, expansion of public programs, individual mandates as to how they take care of the healthcare, how they lead their own healthcare, then employer requirements and incentives, provisions for small employers, delivery of system reforms, and shared responsibility for financing. So these are just some few examples of health reform law. And as you can see, most of them are around one, service delivery, and two, healthcare financing. So now we are going to look at another principle, which is the quality dimension of service delivery. And with the quality dimension of service delivery, you will see that we have two things. We have the quality of service delivery, and we have quality of care. Under the quality of care, we have what is called the Donabedian model for quality of care. So this model basically looks at quality of service delivery from three perspectives. One, what is the structure that you have, that is in terms of physical and organizational characteristics where healthcare occurs. This has to do with buildings, for example, geographical access, how you have designed your building, and all that. Then moving on to the process, which focuses on the care they move to next. And this is where you look at things like process maps and process improvement. Then the last step on the Donabedian model is the outcome. After looking at the structure and creating a certain structure and creating certain processes for the kind of outcome are you looking for? And that is the effect of healthcare on the status of patients and population. Looking further into the elements of quality service delivery, these are the aspects you should always look for. One, timeliness. Is there timeliness in terms of access? Is there timeliness in terms of waiting and action time? I'm sure, especially in our public facilities, we always have the complaint of people are waiting too long, and that's why they go to private facilities. And as you can see, timeliness is a dimension of quality. So if someone tells you they think that there's a better quality of healthcare at a private facility than a public facility, they are right, because if they wait too long to access a certain service, then that means that service is not of good quality. So they will go to where there is better quality, which is a private facility where they'll be served faster. The next thing looking at quality is information. And clarification is done by answering what kind of information, when do you need this information, how will you get it, who will you get it from, and why do you need this information. Competence, which comes down to the healthcare worker. What is their medical knowledge or expertise? This comes down to training. How are your healthcare workers and community healthcare workers trained? What skills and expertise do they have? Are they trained in ethics, bioethics, medical ethics, all forms of ethics that they are required to be trained in order to deliver quality services? The issue of technology and how you use technology and whether it is effective, and completeness of care, and also success of treatment. Then the other dimension of quality, of course, is the personal interaction with clients. Courtesy and respect, as they say, courtesy costs nothing. A number of times you will find, especially when it comes to maternal and child health, you will find women preferring to deliver at a certain facility, not because it's better, but because the healthcare workers there treat them better. So that is the personal interaction with clients, which is an important dimension of quality. Then looking at the environment, including the building, and also the people are part of the environment. So how clean is it? How friendly is it? So looking at further into quality health services, I don't know, maybe by a show of hands, how many people have seen this quality model, the STEEP quality model, which has 6 principles? It was developed by the Organization of Medical Services in the US. Let me just see. By a show of hands, how many people are familiar with this model, the STEEP model? I'm trying to see if there are any hands. No, there's no one familiar with it. Okay. So this STEEP model was developed so that people can be able to, 1, define what quality healthcare looks like, and 2, also be able to measure. So they came up with 6 different components that are essential to define healthcare as quality. So the first one is, the first S is safe. Whatever service you're providing has to be safe. It has to be effective. It has to be efficient. It has to be timely, and it has to be equitable. And we will look at some of these concepts to define what does effective mean, what does efficient mean, what does safe mean, what does timely mean, which we talked about a bit earlier, and equitable in terms of everyone. Do we treat everyone the same, or do we give healthcare services according to need and also according to expectation? So this is the STEEP quality model. So what are the factors that influence quality of care? We have looked at delivery and quality of services. Now we have another dimension of service delivery that we call quality of care. And quality of care refers to characteristics of the system of healthcare that enable it to take care of the client, taking into account all their socioeconomic and disease dimension. So now this quality of care moves from just the services itself, coming down to the system and the way the system interacts with the client. And the system quality of care refers to healthcare as it is delivered in a functional system. And remember, a system is just like a collection of parts which interact or which are intertwined. And at the end of the day, the main reason why you're bringing these system components together is to achieve a certain aim, which in this case is delivering quality healthcare services. So what are those factors that influence the quality of care? One is acceptability and relevance. And this is where the issue of culture and your environment comes in, and the issue of person-centeredness and community engagement comes in, because what is acceptable in one community might not be acceptable in another, and what is relevant to one community might not be relevant. Continuity of care. Remember that patients will come back if they know there is consistency and reliability. And continuity of care can be looked at from 2 dimensions. One, that means the service that this patient is getting every time they come there. For example, if I'm coming for my NCD clinic, I know there will always be an NCD clinic every Tuesday. 2, continuity of care, especially from a family medicine and primary healthcare kind of perspective, is the fact that I know my family physician, who I'm empaneled to, or who I have to go and see, is constantly there for me. So that is continuity of care. So the patient is not only being seen at the same facility, but they're also being seen by the same provider, because patients usually find it very frustrating when every time they come to a clinic, they have to see a new person who has to reread their story, or they have to retell their story to a new person. Whenever they know that I will see the same face, the same person I told my story last month is the same person I'm going to see this month, then that encourages patients, and you'll actually hear that this facility has good services because I will always see the doctor that I see every time. Then the issue of integration of care. This comes down to defragmentation of all the programs that we have within our system. Because right now, our systems are mostly organized on a program basis. We have the HIV/AIDS and care program aside, we have the NCD program aside, then we have a primary care program aside. And this sometimes, especially for patients with comorbidities or multimorbidities, it is very difficult because I have to go to the C6C clinic for my HIV care and then move from there and go to my NCD clinic and see somebody different for my hypertension. So integration of care is a very important dimension of quality of care. So that means we have to defragment our vertical programs, integrate them into one thing, looking at not how the system functions, more into how the patient wants the system to function. And in this way, I want a one-stop shop for all my health concerns. The other dimension is holistic or comprehensive approach. And when it comes to holistic and comprehensive approach, this is where the primary healthcare system really comes in, because the whole idea envisioned by the Alma Ata and also now declaration is to have comprehensiveness at the primary healthcare level. And the primary healthcare was designed to be comprehensive. That means if I go to a primary healthcare facility, 80% of my healthcare needs are supposed to be served by this primary healthcare facility. And in order for comprehensiveness to happen, there are two dimensions or two things that need to be in place. One, you need to have a doctor who is trained to take care of 80% of a patient's needs. And most of the time that is a family physician or a general practitioner, as they call them in UK and Ireland. They call them GPs, but they are trained GPs. That is apart from their undergraduate degree, they have 3 more years to specialize in general practice. So that is what the first dimension. So this doctor is supposed to be able to take care of 80% of the patient's needs. Then the other dimension is the range of services offered. Because if you are not able to offer 80% of services at the primary healthcare level, then you cannot say that you have achieved comprehensiveness. And this is an important thing because a patient does not need to be referred through 3 different levels of care for them to maybe get a lab service or an imaging service. That now takes down the quality of care dimension of whatever service you're offering. Then the next dimension earlier is the issue of community engagement, involvement, and co-designing and co-creation. Most of the time when we talk of community engagement or involvement, and we talk about public participation, that is a dimension of community engagement, but it is not the whole. Community engagement means you go and ask people, what do you need? You don't go and design a program by yourself, either at the Ministry of Health level or the WHO level or whatever level of policy you're working, and then you come and present it and ask them, do you like it? That is not engagement. Engagement means you go back and do a needs assessment with the community, ask them what their problems are, then together with them, design solutions. That's where co-designing and co-creation of solutions comes in. And when you have community engagement, then you will take care of the point number 1, which is acceptability and relevance. Then last but not least, we have availability of adequate, serviceable facilities. A lot of times we have patients cannot access care because it's too far. The facilities are not adequate. Then sometimes you have adequate facilities, but for instance, when you have a dispensary with 1 nurse, for instance, that is not adequate and it is not serviceable. So those are dimensions we have to think about in terms of how we are setting up our healthcare facilities, especially primary healthcare facilities, because if we do not set it up such that it is comprehensive, then you are failing. What are some of the factors that influence quality of services. So that was quality of care. Now coming down to quality of services, there is a number of things that interact to ensure that a service is either of good quality or bad quality. One is human resources. Do you have adequate human resources? Are they adequately trained? Are they, are they healthy? Two, are they well taken care of? So all dimensions of human resources come into decide whether we have quality services or not. Because if you have a healthcare facility where you have one healthcare worker seeing 100 patients a day, then you have a problem. And there you're going to have a problem with the quality of services that you're delivering, because this person, one, is stressed, they are overworked, and because of that, and because of the long queue that they have, they will more focus on clearing the queue than offering comprehensive and quality services. The other issue is facilities and equipment, availability, suitability, effectiveness, and also adequacy. The other issue is drugs and supplies with the same kind of parameters as the facilities and equipment. Then proper decision making within our system. Then poor waste management, that is hospital waste management, can influence the quality of services that you give, because remember, it influences the environment with which you're giving the services. So if you destroy the environment, if the environment is not clean, not well maintained, it will affect the kind of quality of services that you give. Then the other one is standards and guidelines, because we are always told to follow standards and guidelines. So the quality of the standards and guidelines that you have or you produce will also determine the quality of services that you give. So what are some of the key elements for success when it comes to quality of care and quality of service delivery? Number one is the customer focus. Remember, we talked about that earlier, that we want a people-centered system. And people-centered system is about focusing on your client, focusing on your customer. We call them patients and then we forget they're our customers. They have come for a service. So nowadays we find some facilities have stopped calling people who seek services their patients. They're calling them clients, because patient was a word developed by the Greek back when to just mean the sufferer. What you distinguish between the sufferer and one who's not a sufferer. But now we are moving into the dimension of calling them clients and customers. And it is important to focus on the requirements, needs, expectations, and most of all, customer satisfaction. Like for instance, I'll stop here and ask, how many of us carry out maybe client satisfaction surveys or patient satisfaction surveys on a regular basis in their facilities? Let me just see by a show of hands. Anyone? Do you conduct regular patient satisfaction surveys? I can see one hand there. At least there's one person. Oh, sorry. I've moved to the slides instead. I can see two people. I'm trying. Abdullah Hassan and Kiprop Martin Drase. Maybe I can just ask you at this point, what does your patient satisfaction survey look like? And what do you usually aim to achieve by doing that client survey? I'll start with Abdullah, then Kiprop Martin, then Pauline.
Hello, good afternoon, everyone.
Good afternoon.
The management of Federal Medical Center KEFI in Nigeria made it deliberate attempt to form part of its care, part of its monitoring of care. So we do the customer survey and the customer complaint surveys. The customer survey is actually a paper-based questionnaire. We use paper-based questionnaire and sometimes focus group discussion, like in the GOPD we will classify the patients into, the clients into 4 or 5, depending. There are geriatrics, then the women, then the adults, and then there are people with chronic diseases that comes. So each particular patient, we design a questionnaire to each particular person, each particular group, we design a questionnaire to suit their purposes, so that we can be able to elicit from them their perception about the services they just access. In terms of the triage, in terms of the doctor's consultation, time spent, drugs availability, cleanness of the environment, and whether toilet facilities are clean or not. This is what we do. Thank you.
Wow. Thank you so much for sharing. I think that's a very already talked about. Prof. Martin?
Hello?
If you're not speaking, please mute your microphone if you're not speaking. Yes, Kiprop, go ahead.
So I'm saying, as we just said, customer satisfaction survey is actually very important in our key processes. We've actually designed our tool in such a way that we're able to gauge the kind of service that our members are getting. Personally, I work with NHIF. So we've designed our questionnaire in such a way that we ask our clients if they go to these self-care providers, okay, we'll gauge the processes of the kind of service they're getting. Then we ask if there are any gaps, if there's room for improvement, and how best we're able to serve them maybe in the future. Or we're basically about that. That's what we do in our customer satisfaction service, and we do it quarterly.
Thank you so much, Martin, for that sharing that. And I'm actually quite impressed that NHIF does that, because NHIF is not the service provider. NHIF is the purchaser, but wants to know from the client's perspective, the services they are purchasing are quality services or not. Next, we had Pauline and I think Ibrahim. Pauline, go ahead.
Okay. Our survey, normally we do, the questionnaire is an exit survey, questionnaire. And we do give, we have a checklist and we ask them several questions. And we have one person at the customer service who goes around, to talk to their clients. And mainly we want to find out how they find our services, like how are they attended? How long did they take in the queue to be attended? And whether they have any complaint, any recommendations that they can make, to help us improve our services.
Okay. And I think that's also an interesting way of doing it, where you have not a self-administered questionnaire, more of an interviewer going around and interviewing the patients, because I think there is also a kind of dimension that even the person interviewing the patients can get that you would not get even from a self-administered one. Gishuke, yeah. Thank you, Pauline. Yeah. Thank you. Gishuke, go ahead.
Okay, thank you. I think for us, I had a team of staff who ran outpatient services for one of the multinationals, and our survey is for the outpatient centers, which tries to cover client satisfaction in the scope. The scope it uses, we look for in terms of their satisfactions, in terms of whether they receive adequate information about their medical problems, whether facilities are clean, the waiting times, how friendly the staff are at the facilities they visit, how much time they feel they're given, confidentiality and privacy, as well as the accessibility of some of the services that we think they should be available at that place, as well as availability of medication. And then overall, we just ask them about their overall satisfaction with the facility, maybe at present compared to probably a period in the past, to try and gauge improvement. So we use this for just our own system, looking at the medical services system quality improvement from time to time, because when we combine these clients' satisfaction with other measures such as outputs and health outcomes, then it is possible to have measures that we can say we are objectively trying to improve care. So that is usually the entirety of it. Thank you.
Thank you so much for sharing, Gishuki. I think you have even covered things that we are going to cover. You've talked of systems and processes. You've talked of measurement. And I think this is an important dimension that you have to look at apart from what the client says. You have to look at, after you've looked at what the client has said, you have to go back to the system and look at, for example, if the client says, I waited too much from the lab maybe to my next step, which was imaging, or from my consultation to lab, then you look at the system. What within the system is making the patients wait too much? So you focus also on the systems that you've created and the processes. The system is how one component talks to the other. For example, the healthcare worker and the buildings and how the buildings are designed. Then you look at, for example, the lab is placed here and imaging is placed on this other building. Are they the same building? Are they on the same floor? So those are part of the systems within your organization. Then the process is now, how do you move from one place to the other? How do you go through lab? How do you go through reception? How is the consultation process and such things? So those are things you should also look at to ensure that you have quality services. Then in terms of measurement, you always have to define what you are measuring. For example, in your customer satisfaction survey, whatever you are asking, you have to try to make sure it is something that is measurable. For example, one very good example is waiting time. Waiting time is measurable, although it can also be subjective and both objective, because if every time a patient walks into a station, there's a timestamp. For example, for those who use EMR, patient walked into consultation at 10:30, right? And then the time they walked into the lab, the time they were being registered at the lab reception was maybe 11:30. So you know in between how much time that patient spent from one process to the other. And then the patient will also tell you, I waited for 1 hour or 2 hours, which could be quite subjective. But in order for you to improve the process, you have to be able to measure. There's that whole framework of quality improvement and how you, first of all, identify what you're going to measure, how you're going to measure it, and then finally how you're going to improve it. Then last but not least, teamwork. I think some of you might have joined some of our meetings where we are emphasizing, especially at primary healthcare level, the issue of teamwork. Teamwork really makes the dream work. When you have different healthcare workers, different cadres, even different people within an organization working together as a team, all the way from the reception to the time the patient leaves the gate, then you will be able to deliver quality services, because the person at the gate might tell you, oh, I have an emergency here. There's a patient who looks like they need help. So that person at the reception then calls the nurse, and you actually catch an emergency before it even gets worse. That is teamwork. And a teamwork approach, one, to service delivery, and two, also to problem solving and quality improvement, is the best vehicle for achieving quality in healthcare. So when you're having your quality improvement meetings, when you're having your quarterly meetings, quarterly reviews, monthly reviews, involve everyone, including the person who welcomes the patient at the gate. You have to involve everyone in the process if you want it to work, so that everyone understands, one, we are a team, we are a system that is interlinked, and all our processes are interlinked, and our problems can be solved better when we come together. So we are emphasizing that issue of teamwork. Next, we are going to look at patient and family-centered care. And I'm going to spend a bit more time here because this is something that it might be new to some people, but not new to others. It is actually a course. You can actually be trained in patient and family-centered care principles, because like I mentioned before, even the WHO building blocks added people at the center. So everything nowadays is about the people, it's about the population, it's about the community. So you have to understand the principles of offering not only patient-centered care, but patient and family-centered care, especially for those who work at the primary healthcare, in a primary healthcare setting, and those who are also leading primary healthcare facilities and systems. So what is this about person and family-centered care? So this is an example of a patient and family-centered care model from the Western Health staff and physicians at the Western Health Hospital, where to them, what does it mean to have person and family-centered care? One, the issue of partnership and participation. I'll give an example of, for example, you want a patient who has hypertension and it is stage 1 hypertension to probably engage in diet and exercise to reduce to reduce their blood pressure. So how are you going to approach it? One, in a patient and family-centered environment, you do not approach the patient by themselves. You ask them things like, who cooks your food? You know, who does this at home? Where do you live? And then you come together. If it is the wife who cooks and the husband is the patient, then the wife has to be present in the consultation when you're talking about reducing salt in the food, reducing fat in the food, because if he's not the one cooking, how will he ensure that there's no too much salt in the food? So that is just an example of an approach where there is partnership and there is participation of the patient. And then you have to ask the patient, what do you think you'll be able to do? Running, walking, what's good for you? How much can you do? And then you agree. It's not a matter of you telling the patient or telling the family what they need to do. Information sharing. A patient needs to have all the information they require about their disease, about their health status, and if possible, if they ask you to print out their medical records, including the doctor's notes, you are obligated to do so because that information is regarding their health, their body, and their care. So that is a patient and family-centered approach. Then dignity and respect. We talk about the kind of interaction you're supposed to have with a patient or a client is supposed to foster dignity and respect. That means no shouting, you know, no condescending remarks. Ensure there is privacy and confidentiality. You can't see patients, like, you know, whenever you have a consultation room that is open and then everyone can hear you what you're asking, or you're asking at the reception, you want to know at the reception the reason for someone's visit, yet there's a whole queue of people waiting and hearing what you're saying. That is not right. So you have to think about that. Then collaboration, that means you collaborate with the patient and their family for better health outcomes. So this is the patient and family-centered care model. And I assure you, if you design such a model for your facility, for your healthcare systems, then the patients will never stop coming. Even if they're just coming for a health check, they're not sick, they will come because you're treating them well. There's collaboration, there's partnership, there is respect. So this is another, a few more concepts that you have to consider when you're designing a patient and family-centered care kind of model. One, decision-making. Remember, we've talked about participation, we've talked about partnership and collaboration. So how do you make the decisions together? Social support, always ensure that the patient and the family have social support. And where there is none, you have to work with communities to create a social support structure. Information seeking, how do you get information from the patient, from the community, from the family, and how do you share information as well? Then the care burden and family resilience. You find that there are some families where it is only one person taking care of 2 sick grandparents or parents, or it is burdensome for them to buy the drugs that you're telling them to buy. It is burdensome for them to go on the diet that you're asking them to go to, the kind of diet you want them to do. Probably they cannot afford it. You have to think about such things and what burden the care that you design has on a family and has on a patient. Then the quality of life issues, because sometimes you have a 99-year-old with end-stage cancer and you still want to go in and operate. Think about what is the quality of life after I institute care. So those are things you have to think about. Am I improving the quality of life, or am I just going to burden the family and then not improve quality of life? And whatever I'm doing, will it improve the quality of life of both the individual and the family? Then siblings' needs, parenting styles, because people have different parenting styles. Patients, you have to think about this in a patient and family-centered care model. Then parental stress, and also cultural and spiritual care, because someone will come and tell you, you will talk not even to them, at them, and tell them something, but they'll tell you, for me, when I'm sick, I go and my pastor, my shaman, my imam prays for me and I get well. And some of them will tell you, I don't believe that medication can work without prayer. So you have to consider all those dimensions when you're doing the patient and family-centered care. Remember, it is not about you. whether you have those beliefs or not. It's not about whether the healthcare worker believes in God or not. It's about whether the patient and the family does. So let us move on to the next concepts, which are the concepts of access and availability. So what does access mean? Access simply means that healthcare services are unrestricted. They're not restricted by either geography, economic situations, social situations, cultural situations, organizational or linguistic barriers. So when you're looking at the and look at geographic access, look at economic access. The issue of healthcare financing comes here because, like we mentioned, to achieve universal healthcare coverage, you have to ensure that there is no catastrophic health. So you have to ask yourself, these people accessing these healthcare services, how are they paying for them? Then the social dimension of accessibility and relevance, cultural dimension, organizational, such that you don't have an organization, for example, where we have some faith-based organizations that deny women family planning services because they do not believe in family planning services. That already is a barrier. And linguistic barriers, which can be in the form of, I don't speak that language, the healthcare worker does not speak that language, you do not have a translator present to translate. So that is a linguistic barrier already. So that is a dimension of access we need to look into. And the second one, which I want to propose as a challenge to all of you, how many of you have someone to interpret for the deaf and the dumb? How many of you have a sign language expert stationed at your facility? Let me see by a show of hands.
Wants to come out here.
Pauline, do you have a sign language translator at your facility?
No, we don't have.
Oh, I see your hand raised.
It's a gap.
Yes. All right. So you see, nobody has. But do we get deaf and dumb clients who need a sign language translator, or do we not? Or are we ourselves trained in that? So that is something to think about. Then in terms of availability, that talks about the volume and type of existing services to the volume and clients and their needs. So if, for example, people need family planning services, and then it's at the dispensary and you don't offer them, that is already a barrier to access. So availability can as well be a barrier to access. So think about, are these services available and should they be available? Because like, I'll give an example of Kenya where we have the essential drugs list, which basically means dispensaries, that is level 2 and 3 health centers, do not get NCD medication. That is, there are some dispensaries that don't get hypertension medication, diabetes medication for your epilepsy. That means any patient who needs that has to travel all the way and go to a level 4 facility, which might be far, in order to get that. So when you think about availability, then you know that you need to have that medication at that level because there are patients who need it. Access further and how you measure it, there are several ways you can measure it. And the WHO actually has a very wonderful tool, which I love, that is called Access Mode. Access Mode actually measures geographic access to different facilities. So it measures the distance between any homestead that you have on your map and a healthcare facility. And not only a healthcare facility, you can actually input data such that it measures for you if that facility, for example, has delivery services, and the difference in distance between those delivery services and a woman's home. So Access Mode can help you. I'll put that in the chat later. You can go and look at Access Mode to help you with geographic access. Then in terms of access dimensions of availability, you can do service availability mapping service, like I've mentioned, where you don't only map the facilities geographically, you also map what services they provide and also the range of services being provided. Then for accessibility, you can do specific access surveys where you talk to patients, and you can also do something like I've mentioned with Access Mode, which can show you geographic accessibility. Then in terms of affordability, the national health accounts can show you that it can pay out of pocket, how many patients pay by insurance and how much insurance pays, and whether they are able to pay that. And household surveys can also tell you if after paying for that service, they went into catastrophic healthcare expenditure if you want to go further. Acceptability, the client satisfaction surveys and the examples that you've given earlier, those ones are very good to check acceptability, because like I'll give you an example of COVID vaccination and why COVID vaccination was stalling in some countries. In countries where Islam is the predominant religion, men are not supposed to attend to female clients. So most of the vaccinators in these countries were male. So most of the women did not get the vaccine. So it was only after the WHO and the team went in there and did a survey that they realized there are very few female vaccinators. That's why the women are not getting vaccinated, because they're not supposed to be vaccinated by male vaccinators. So that is another dimension that you can look at in terms of measuring access. So just a recap on access, it has to be physical, whatever service has to be physically available, affordable, acceptable, and also appropriate. So now we are going to move on to look at efficiency and effectiveness. And these are just some illustration as to how people think about these two concepts. Efficacy means I can do it right. If it's a physical exam, I can do it right. If it's a prescription, I can do it right. Efficiency means I can do it quickly and economically, apart from doing it right. And then effectiveness means I can do it well. So that is a summary of a simple way of thinking about it. So efficiency aims to achieve more using the least of the available resource. So in the realm of achieving efficiency is where now the issue of lean healthcare systems comes into play. And when you look at lean healthcare systems and achieving more using the list of available resources is now how you look at, for example, the issue of comprehensiveness and a visit, how long a visit is supposed to be and what it's supposed to achieve. Because every time a patient comes for a revisit, they utilize not only their own resources, but also system resources. So that is now efficiency, thinking around the issue of efficiency. And it is achieved when allocation of inputs, that is the healthcare workers, health products and technology, the time you put in etc., produces the exact quantity and quality of service possible cost. So remember, cost here is an important thing, because we keep talking about how do we lower healthcare costs. And one of the way of lowering healthcare costs is lean healthcare systems that reduce waste as much as possible. An example of this would be every time a nurse has to take blood pressure for a patient, she has to go into a room, bring out the blood pressure machine, cross over and go to where the patient is, take the blood pressure, cross over again, go and write in a book, and then come back and sit down and continue registering patients. As you can see, the patient, that is a waste that is associated with what is called motion. So how do you reduce that waste? You reduce the distance that nurse has to cover just to take a patient's blood pressure. That is an example of how you can utilize efficiency to improve the quality of service delivery at a lower cost. Then effectiveness aims to ensure that the interventions we prioritize are the ones that give our clients the best possible health outcomes. This is where now assessment of health products and technology comes in, where you assess the effectiveness of a drug, the effectiveness of a single intervention, and seeing that this is where you do now your cost effectiveness analysis, impact analysis, to ensure that if I decide nationally to roll out this intervention and say, for cervical cancer, if I vaccinate all the young girls between 10 and 14 years, in the next 5 years, I'll reduce the burden of cervical cancer by this much. So there you're looking at effectiveness, and one, effectiveness of the service you're giving, and two, effectiveness of how you're delivering that service. Then the which we had mentioned in the 6th dimension of quality of healthcare is safety, which is number 1 on the STIP model. So safety has 2 dimensions. You have healthcare worker safety, and you also have patient safety. Under healthcare worker safety, we had the World Patient Safety Day on 17th of September, which was mainly the theme was around do no harm when it comes to giving medication. But also some of the messages were around having a safe and supportive work environment for healthcare workers. And as you'll see on my next slide, the health of healthcare workers and the health and safety of healthcare workers and the health and safety of patients is intertwined. Because, for instance, when a healthcare worker is stressed and overworked, that increases maybe their chances of making a mistake 10 times. Maybe they'll have a needle stick injury and in the process also injure a patient. Patient safety, on the other hand, is an interlink between different things within the system. So system variables that affect patient safety are things like the environment, the culture, the system device design, and also human factors. That is why I mentioned and said healthcare worker safety and patient safety are interlinked, because human factor actually factors in for about 75 to 80% of patient safety needs and concerns. And then whenever any of these system variables, there's a problem with system variables, it results in a system failure, which results in an adverse event. That is why we always encourage people, do not have a blame culture where you single out a single healthcare worker and say, it is your fault the patient died, it is your fault the patient fell, because it is never one person. It is usually a system failure. Many of these components, the environment, the culture, the human factor, and the system interacted at one point in time, bringing about the adverse event. That is it for safety, because I didn't want to go into the nitty-gritties. Let's look at referral in health systems. Referral is an important part of health service delivery because, as you can see from the organization that we have for most of our healthcare systems in Africa, starting from the community level to maybe level 4, 5, 6, depending on your organization, there are certain services which are not usually available at a certain level. For example, at the primary healthcare level, you don't expect maybe to have a surgeon with a maybe surgical institute at the primary healthcare level. So what happens? You will need to refer this person from a primary care level to a secondary or tertiary care level where they will find the service that they need, and not only refer them to a higher level, but refer them to a higher level in a timely manner, in the most efficient way, and ensure that wherever you are sending them, they will get the service that they need. So what are the principles of a good referral in a health system? One, adaptability. That means this system should be economically feasible, epidemiologically and culturally feasible. So however you choose to do your referrals, from the time that you decide, you make the decision that I am going to refer, you have to consider a lot of things. Maybe socio-culturally, you have to consider. In some societies, in some African cultures, it is the man who makes the decisions. So if you refer a woman for a cesarean section without her husband, she will get on the other side of the hospital. When she's asked for consent, she will say, I have to call my husband first, the husband that you left behind. So it has to be adaptable to the socio-economic and cultural context. Then the issue of urgency. Is this an emergency? Do I have to go right now today? Is this something that can wait? For example, it's a cold case, a surgical cold case that can be operated on later, but I just need a surgical review from a higher level. So you have to consider such things. The coherence of the diagnosis. Please do never refer a patient when you do not know what you're referring them for. Because sometimes you refer a patient and you don't even know what they're suffering from or what the problem they have is. So the diagnosis has to be coherent enough to inform a good referral. Then there has to be ability and availability to provide the service that you're referring the patient for. Don't just refer to a patient, or let's say I'm at a health center, so I know district hospitals do something, maybe they have a theater, but I don't know what kind of services are offered in that theater. So I will send a patient because of a structure, a theater, but they get there and the service, for example, they say, I need a hernia repaired. They tell you, no, our theater only does cesarean sections. It does not do hernias. So you have wasted a patient's time and you wasted system resources and also patient and family and community resources. So you have to consider where I'm referring this patient, is the service available and when and how is it available? Then reliability of the service provider. Like I mentioned, we have problems within our systems where sometimes you find that there are commodities that they are missing, drugs are missing, maybe a healthcare worker, there's only one surgeon in the whole county. So when you refer, the surgeon is on leave. How reliable is the service provider that you're sending the patient to? Then availability of services, which I've already talked about. What are some of the other principles that you have to consider? One, organization and prioritization. Please everyone in the system, from the person doing the referral to the person receiving the referral, you have to be very clear about what your role is, what your responsibilities are, and what your limitations are. And you have to have protocols of care and conditions for that level of service. But you know, whenever we receive a referral, there's a referral protocol, because a patient who comes by referral and a patient who is within your facility, they should be under different protocols until that patient is received into your facility. And you always have to have a suitable means of communication and also transport. So this comes down to, how do you manage your ambulance services? Are they centralized? Are they disintegrated or fragmented? And then who manages them? Because sometimes if you do not have fleet management experience or fleet management expertise, you're better off leasing the service of, for example, of your ambulance to a fleet managing company that can organize for you how the ambulances move, how, when, and where. Because sometimes that is where you find the confusion comes in. And then 80% of all adverse events are caused by miscommunication. That's why communication is important, and you have to have a good communication tool for referral. My favorite is usually the SBAR. You can go and look it up. Just when you Google SBAR, the SBAR model of communication, or the SBAR tool, it will show you the tool and it will show you how to use it. This is what we had been training for. We had a program for emergency obstetric and neonatal care, and this is the communication tool that we were training the healthcare workers there. They were clinical officers, anesthetists, and nurses, and we were training them how to use these tools for efficient referral. And I find it very efficient and effective. Last but not least, we have to look at community health service, because most of our health service delivery at the community level is done by community healthcare workers. So who are these community healthcare workers? They are simply frontline public health workers who is a trusted member of a community and has close understanding of the community needs. And they usually serve as a link between the community and the healthcare system or the health facilities. And in terms of now healthcare workers, there's a whole, I'd encourage you to go back and read the module, because there are certain things that you have to consider when you're setting up your community health service. One, recruitment and selection process for your community healthcare workers. It has to be clear, it has to be concise, it has to be acceptable to the community. Two, remuneration. One of the things we are calling for in our Afro-PHC policy framework is professionalization of community health workers. Because how do you expect someone to be working for you, doing referrals, doing house visits, but you don't pay them for their time? So we are encouraging all African nations to professionalize community health service, treat them as workers, treat them as part of the health service system, and remunerate them accordingly. Then in the issue of supervision, you have to have regular supervision with the community health workers, ensuring that they stay in the bounds within which they have been trained. For example, you cannot have, if for example, your community health workers, depending on your policy framework, are not allowed to be giving vaccines or giving medication, then you have to ensure that that is not happening. So close supervision is very important. So the person at the link facility who's supervising healthcare workers needs to have a clear supervision tool and a clear guideline of what they can and cannot do. Then in terms of training, they also have to be trained on how the system works, trained on the processes, and all health education and health promotion, because that is what they do in the community, or that is what they should help do in the community. Last but not least, quality accreditation, and I will not go too much into this because it is a whole other course. And the issue of quality accreditation, remember, quality accreditation and quality improvement and quality assurance are three different things, but all of them come down to you wanting to be accredited. And the issue of being accredited, for instance, I'd give an example of Kenya is, if you're accredited, that means you are a service provider that is trusted and has been licensed to provide a certain service. And that also means a purchaser like NHIF can give you money to give services to the population. So that is the importance of accreditation. One, not only to gain the trust of the population, but two, also to show that you are complying with standards and regulation. So the main principles of quality accreditation, make sure that the patient is center in that in the accreditation process. So make sure that all the processes that you want to get accredited, you have tested them with your patient, they're acceptable to your patient, and they will work for your patient. Improving safety in healthcare. Quality improvement is an important part of quality accreditation, so that you are not just given, for example, ISO certification or any other kind of certification once, and then you sit back and relax. No, it is a continuous process going to the next point of continuous improvement. And there has to be involvement of professionals working in the facility, because a lot of times you just hear accreditation, but the healthcare workers in the facility don't know what is supposed to be accredited. They don't know what processes are supposed to be accredited and improved. They just hear today, make sure everything is clean and it looks fine. We have visitors who are coming to do accreditation of the facility. Make sure from the get-go you involve all the professionals within the organization so they can back you up, and so that when it comes to continuous quality improvement, you also have champions. Then remember to be very objective. Do not be subjective. This is my facility, I want it to do well, so you try to alter some measurements and such like things. It's important that you be objective during the process, if you're the one doing the assessment or you're the one being assessed. And assessment and continuous improvement are part of the accreditation method. That's why sometimes someone will come and do an assessment, then wait 6 months or 3 months and come back and see whether the improvements that they had recommended have actually been done. And with that, I end of my presentation. And now I'd like to ask any questions and any kind of clarifications you might need from anything we've talked about today, or maybe something that you read while going through the module. And I want to encourage us all to raise our hands to engage in discussion, because I'm not an expert, and I'm sure there are people who are experts in different things that we talk about today who could have the answers as well. So over to you. Go ahead, Rael.
Good evening, colleagues. I'm Rael Akoru from Turkana County. During when the program started, the class, this session started, you touched on the issue of patients taking a lot of time in government hospitals, ending up going to the private facilities. My experience is that actually what they get from the private facility is not as quality as what they get from the government public hospitals. In the private hospitals, these are customers, they are not clients, so they are bringing money. So you have to do things the way they want, not as compared to the government hospital. You have to undergo that process of diagnosis. You go to the lab, if it's 30 minutes, that's the 30 minutes. But if you go to the private hospitals, there are some services which they don't give, because they want you to believe that they have given you, they have shortened your time of stay. I had that experience because I wanted to find out, why do this private hospital take less time? So I went and I presented my case, but my sample was taken to the lab. The sample, which was supposed to take a minimum of 20 minutes, I was surprised. Within 5 minutes, I got the results. So I went, so that's what we have always to explain to our clients, that what you get from those private facilities is not what you get from the government hospital, because they always do misdiagnosis, because they do guesswork. They do not make people go through the diagnosis, the investigation, and what. So ending up confusing. At the end of it all, that mismanagement from the private facilities, it becomes complicated. They come back to the hospital. Thank you. And also the issue of interpreters. I wanted to get an okay. There was a time during COVID 2020-2019, Kenya organized an online class 1 week for sign language. I joined one, so at least I have some basics about sign language. I don't know whether I can forward the link to this page, because I don't want to forward anything which is not related to this page. Thank you.
Please go ahead. I think that one is very relevant, and congratulations to you for doing that. Yes, and one of the things that I wanted us to take home from this is how service delivery interacts, because the reason why in the public healthcare system things don't work is because of how the thing prioritization and organization. Because I believe that the public healthcare system can offer even better care than the private. But the thing is this: why would the same, for example, healthcare worker be nicer at a private facility than they are in a public facility? At the end of the day, the human factor, how we choose to do our work, and how as managers we choose to organize. Because remember, this course is teaching you either to improve as a manager, to go into management as well. You can actually organize a public facility to run even better than a private, but it's just a matter of prioritization and organization, ensuring things run on time. For instance, sometimes the things we have is a public health facility is supposed to start services at 9, but the healthcare worker comes in at 10. So there are things within the public healthcare system which need to be corrected so that that can be done, because at the end of the day, we need to respect people's times. We need to respect people's wishes as well, whether in the public or private. That's why I brought in the issue of patient and family-centered care. It is not for private facilities only. It is for us as managers and healthcare workers to ensure that we deliver patient and family-centered care kind of services. Otherwise, the same thing will continue happening. And the reason why the private has focused on time is because they noticed, they did a client satisfaction survey, and they noticed the clients are complaining about time. So they made everything faster. And that, to their clients, they're offering quality, because the quality dimension that the client is looking for is timeliness. So you have to ask yourself, whatever facility I am, whether public or private, what is the quality dimension that my client requires of me, and then prioritize that over maybe something else. Not that you reduce the quality of diagnostics or whatever, but find a way of doing what you're doing faster, but at a lower cost. For example, you can decide in the morning, you talk to the community, right? You tell the community, on Tuesdays, we will be doing blood tests for everyone. They will all come. And then you do them in batches, such that someone collects the blood very fast, takes it to the lab, for example, for the NCD clinic. By the time they're seeing the clinician, they have it there. So it's just a matter of thinking outside the box. How do I provide the service I'm providing with the number of people that I have, but I provide it faster, and I also provide it in a timely manner, but at a lower cost. I don't have money to buy an extra machine, but what I can do is I can analyze the samples, for example, in batches. And that is what private facilities do actually. So thank you so much, Rael, for that comment. And I hope I've answered your concern about the issue of public-private. Let me see if there are any more raised hands. Raised hand. Sorry. Anyone else? Anthony, go ahead.
Yes, oh, sorry.
I'm seeing Anthony Muruga has raised his hand. Go ahead. We can't hear you. In case you're speaking, we can't hear you. Okay, anyone else?
Yes, good afternoon. I'm Ophelia from Mozambique.
Hi,
Thank you. So I just want comment something about the organization of service. We here in Mozambique, we note that there is a different kind of service. For example, In my clinic, I attend people with chronic disease, but especially hypertension and diabetes, things like that. So the same patient, for example, if he has a HIV, so he go to another hospital to have a consultation for HIV, and then they came in our hospital to control hypertension, diabetes. So this is, I think, well, is a big problem for us and also for government, because sometimes we lose all this patient because it's too work for them. Also, I would like to comment about hospital, private hospital and in public. I know people, well, most of the people who came in public, people consider like, well, they are low income, no money, and then they don't treat very well. They treat like, you know, you are poor, you are here to get the service free, to get the service free, and then you can complain. It's like this. But the same person, if they go to the private hospital, so the kind of treatment is really different. So I think also, as you said, we need to, the first we have, like, we need to have humanity to treat people in the equally. Because if we do this difference or make this kind of difference, we will not achieve equality in health service. Just I want to comment. Thank you.
Thank you so much for those comments, Ophelia. They are quite relevant. And I like how you've mentioned the issue of humanity. You know, just treating people as human beings, having that compassion and kindness, I think it is something that can go a long way. Thank you. Mungabo, go ahead.
Good afternoon, everyone. I am Mungabo from Lusaka, Zambia. In regards to what Ophelia was just saying, yes, I agree very much. I think there's like an element of just morality and just, we need to be less classist, I think. Especially in regards to the type of clients that we're interacting with. Even just most of us, though, I think it's a bias most people have. Even the way they speak changes, their attitude do change. I don't know if inherently people assume it's social capital. Maybe there's something I can get back from this person, but either way, it's wrong, and we need to check ourselves. In regards to the issue with trying to integrate care, I think for Zambia, what we've been doing from as far back as 2020, in our national HIV guidelines, we really emphasized integrating NCD care with HIV care. But then the NCD care was biased. There were only 3 parameters. It was hyperglycemia, high blood pressure, and hypercholesterolemia, because we know that they are direct side effects of the typical triple therapy that we provide. But then I think what's been happening now, what's been happening over the last 2 years, maybe COVID slowed things down, but implementation was the problem. Everything is in the guidelines. Everything is always in the guidelines, but the policy is always beautiful, but just implementation has been the issue. And so now what's happening is different programs are trying to carry out studies and just teach the clinicians that are usually found, usually in the ART clinics, which work very beautifully in our country. We've got some great success stories. They're just trying to teach them how to, just the basics around checking blood sugar and so on and so forth, and just integrating the test so that we have better NCD, HIV integrated care from one center. Yeah.
Wow. Thank you so much for sharing that, Mungabo. I think integration of care is one of the things that really hurts us and hurts our patients when they have to see 15 million people for the same patient seeing 15 million people for different things. So thank you for sharing that. I think a lot of us can borrow from what you have done. Anybody else? Let me check for raised hands. And in case I'm not seeing you, can as well just unmute and speak. Let me see. Okay, I am not seeing any raised hands. So thank you so much, people. I just want to encourage you. Was there someone who wanted to talk? Let me not block you.
Yes. Sorry, Mercy. I had a follow-up, more like a question then. When it comes to, for example, the case we're talking about, integrating NCD and HIV care, everyone knows that the side effects of the typical antiretrovirals we're using can cause hyperlipidemia and so on and so forth. And we know that. But but as nations, and then we, for example, we come up with guidelines, and I use that sparingly. WHO comes up with guidelines and makes them country specific. And so we know what we're supposed to do. We know the tests what we're supposed to do. And yet it seems like we have to wait for an academic at some academic institution to apply for a grant, to come and do a study, to see the feasibility, then to try and implement. We wait so much. We know what to do. It's not very complicated. You just need a glucose stick to check for sugar, or you can use the urine. It's the only lab test is like is the biochemistry for the cholesterol levels. But then for the high blood pressure, you just need the machine. I honestly don't know why, at the very least, even just checking the BPs, why that has been an issue when we've known this for a while.
I think, Mungabo, one dimension that we have to look at is culture. Like I mentioned earlier, culture is strategy for breakfast, lunch, and dinner. So what is our culture?
Say that again? Culture is?
I'm saying culture is, culture is strategy for breakfast, lunch, and dinner. So a lot of times when you find something is not implemented, there's a culture dimension towards the implementation. Okay, that is one. Two, I believe the only way forward to integrate services is to strengthen primary healthcare services by taking a team-based approach, where you have a family physician or a general practitioner leading a team of people to see people, not as diseases, as HIV patients, as NCD patients, but no, as a patient. And that patient, then you ask, what is the problem of this patient? And you see them that way. Not that they go to an NCD clinic, HIV clinic. We stopped seeing diseases, we start seeing people. So I think that would be our only way forward in terms of integration. A team-based approach at the primary healthcare level that offers comprehensive services, but a team-based approach seeing patients and population, not diseases. Because right now we are seeing diseases and we are very good at seeing them. We see HIV, we see hypertension, we see diabetes, but we are not seeing and taking care of populations and people. So if we strengthen our primary healthcare systems by one, ensuring that we have comprehensiveness in terms of the healthcare personnel there and the range of services, and then we have a team of people, a nurse, a doctor, a social services person, a health promotion person, and then these people are seeing this community of people, then that would be integration. Mrase, go ahead. I hope I've answered you, Mungabo.
Yes, thank you so much.
Thank you so much, Dr. Mercy, for your nice presentation. My name is Wilbert Mrase from Tanzania. I have a few contributions. I think we need also to review our training curriculum so that we can see how have we incorporated the issues of service delivery, because that is very important. So that once our students graduate from a training institution, they can also offer these services to our client.
Agreed.
And then also, again, we need also to do what we call a regular supportive supervision to our colleague, because that will also help to see whether our clients are satisfied or if they are not satisfied. Again, also we need to think about how best can we empower the leaders, hospital leaders, so that they can see how they can make a proper strategy to motivate staff toward achieving client satisfaction. Thank you.
Thank you so much, Rase, for that important contribution. And I just wanted to put in the chat, what is it called? A link to the policy document that Afro PHC is developing, and you will see a lot of the concepts that we have talked about, that you have talked about, are in the draft policy framework, and you can have a look at it and see whether it speaks to your context, it speaks to what you want, so that you can interact with it. We will be launching it at the end of this year, so I hope you will have had time to interact with it and see that these principles that you want to see incorporated in our service delivery, have they been covered?
Thank you.
Okay, anybody else? We are winding up today. I have loved this session and your participation. I love it when the session is...
Hello?
Yes, go ahead.
Yeah. Hello. Good afternoon, everyone. My name is Dr. Somba. I'm in private practice for many, many years, and I work in Nanyuki. I would just like to applaud Mercy for a beautiful presentation. I think it's an eye-opener, especially in private practice. But one thing I'll say, the difference between private and government is that in private practice, we view our patients as an immediate employer. So we are bound to make sure that the patient satisfaction is the utmost because they're immediate employer. But in public, for example, I think the patient there is actually an indirect employer. So you may not have that contact or feeling that you need to please him or make him feel like he's wanted or something. But in private, we are very, very cautious about how we treat our patients, not patients as such, but our customers. And most of our systems are actually custom or people-centered. What Master has told us that is what we do here, or what most of the private hospitals do. In fact, sometimes we go in further and make sure that we even have their room where they can be comfortable. Sometimes we offer them small things, like drinks or something. We actually make sure that all the people that come to us, they have a living memory at the visit of that facility, so that they also go ahead and make more people come. So ours that's how we work in private practice. And that's why somebody commented that it's not really, and I think some must be clear, we don't make mistakes because we are very cautious. If you make a mistake, not a mistake as such, even a misdiagnosis, because that has to be like the end of your facility. And since you're out there, you can also be litigation very high. So we are very cautious and very careful on how we handle our customers. I think that's the main difference between private and public. Thank you, Mercy.
Thank you, Dr. Somba, for those insights. You have heard it straight from the horse's mouth, what they do in private. They are patient, they are person-centered, and they go the mile to make sure that they deliver what the patient expects is quality. Thank you so much for sharing, Dr. Somba. Clyde, and then we wind up.
Thanks, Mercy. Thanks, colleagues. Speaking from South Africa, I have been in GP practice as well as private sector practice for a very long time. I'm now doing what is called a medical advisory work, which looks at the strategies around delivery of healthcare. And your presentation touched on a lot of issues where there is a tendency to now go towards patient-centric healthcare or person-centric healthcare, as well as looking at value-based outcomes. And if you look at the pillars for value-based outcomes, it encompasses a lot of what you shared in your presentation, because these are the tools that one would require to improve the normal delivery of healthcare within the public sector, which unfortunately, despite the amount of money that is thrown at it, there is very little transition into good quality service. And we always say there is no money. There is money. It's how we manage our processes, how we manage our staff, how we manage our facilities. And if we improve on that, it will then make sure that we are respecting this person-centered healthcare model that we would like to drive and give value. And I think this is where we are falling short in the public sector, is that the value that we are affording to our, and you know, the word customer makes it very clear that it is something that is rewarding, not necessarily financially, but from an output value and output structure. So I thought I'd just share that with you guys, and I really, really appreciate this candid approach to looking at healthcare delivery. Thank you, Mercy.
Thank you so much, Clyde, for those wonderful insights and also introducing the concept of value-based care and value-based care delivery. I think you've covered like the whole spectrum of what we need to do in the public sector to move up and to move on. So thank you so much for those wonderful insights. And I am seeing no raised hands.
Share the
sorry?
Share the presentation, eh?
Yes, we normally upload, when you go to the Afro-PHC website, I've put links in the chat. We normally upload it and also the recording. So I will check and make sure we have uploaded them, and then you can access them from there. Is that okay?
Yep, thank you, Mercy.
All right, great people. Let's keep going. For those of us who have fallen a bit behind in the modules, let's keep going. I want to see as many of us graduate as possible in January with the course certificate. So let's keep on going. Let's keep encouraging each other, even on the WhatsApp group. And I'll see you next month. And in case you have questions, you have the Google group, you have the WhatsApp groups, and you have the Afro-PHC email. Please feel free to reach out. I wish you all a wonderful evening, and hope to see you next month. Bye-bye, everyone.
Bye-bye, Mercy. Thank you so much.
Bye-bye, everyone. Thank you so much.
Bye-bye. Bye-bye. Thank you.
Bye-bye,
Bye-bye.
Bye.